Okay. Well, hello, everyone, and welcome to another episode of Scoliosis Dialogues. This is the official podcast of the Scoliosis Research Society, and I am your host today. I have the pleasure of interviewing some of our IMAST award winners. So, as most of our members are aware, we just had our 32nd annual IMAST a couple of weeks ago in Glasgow, Scotland, and we have some of the authors here who won awards for their excellent abstracts, and I had the pleasure of interviewing them. So I'd like to start with everybody just kind of giving a brief introduction, where you're from, and maybe the title of your paper, and then we can kind of go through one by one and do a quick hit parade of what our listeners need to know about the research that you put together and what the take-home points were. So I'd like to start with our best clinical research paper, the 2025 Whitecloud Award. This is Dr. Sardar.
Yeah, thank you very much, John. So I'm Zeeshan Sardar. I'm an orthopedic spine surgeon at Columbia University in New York. Our paper was titled Age-Adjusted Alignment Goals Inadequately Represent Asymptomatic Adults and Are Prone to Undercorrection. This was presented by Dr. Lenke on behalf of our group, and I guess we'll give the summary a bit later.
Sounds good. Thanks for joining us. And next we have Dr. Jain. And Dr. Jain won the Innovation Award.
Thanks, John. Hi, everybody. My name is Amit Jain. I'm an orthopedic spine surgeon at Johns Hopkins in Baltimore, Maryland. Our paper was Comprehensive Skeletal Maturity Index Obviates the Needs for Sanders Hand X-rays. I'm looking forward to having a discussion around that. Thank you.
Great. And then we have, for the last paper, two guests to discuss the winner of the IMAST E-Point Award. If you could introduce yourselves.
Hello guys, this is Dr. Xuanjie and Dr. Jie from Nanjing Drum Hospital. Our center is one of the largest scoliosis center in China, and we are mainly focused on treating the complex spinal deformities. And our recent study entitled "The Princess of Compensatory Curve Predicts Postoperative Curve Progression in Congenital Scoliosis Following after thoracolumbar hemivertebra resection and short fusion," has recently get the E-Point Award in the in this meeting, and it is presented by the Dr. Zhen Liu. Thank you, everyone.
Great. Well, thanks to all of you for joining us. So why don't we get right into it, and we can hear first from Dr. Sardar. He can tell us about the main results and design of this study.
Yeah, thank you very much, John. So yeah, this is, and as we all know, alignment in adult spinal deformity patients is quite important. We've been discussing different alignment goals, I think, for the past couple of decades. And as we continue to evolve and understand more and more, I think we continue to investigate this topic more. And so one of the quite commonly used concepts in alignment has been the age-adjusted goals target, which has been around for almost a decade now at this point. And the main concept of this age-adjusted alignment lies under the premise that older patients, as we age, have a little bit more or have a little bit worse patient-related outcomes or a bit more disability compared to the younger patients. We also know that as the sagittal alignment of patients becomes more and more positive, as they lean more and more forward, their disability tends to increase. And so the age-adjusted concept essentially is that older patients don't need to have the same alignment as younger patients, and that older patients would be okay if their alignment is more forward, if they're leaning forward more compared to the younger patients. And some of the reasons behind this work was also to try to decrease the risk of mechanical complications such as PJK. However, over the years, what we have seen is that adult patients are coming in to have surgery. They're really coming in with the expectation of being able to stand up straight. They're not really coming in for us to operate on them and then leave them quite a bit forward. And so what we wanted to do in our study was to look at a large cohort of asymptomatic volunteers adult volunteers from the age of 18 to 79, and to see what their alignment was like and if the age-adjusted goals would match with their current alignment or not. So this study was based on the means cohort, which is a cohort of about 468 adult volunteers from 5 different countries, including the US, France, Tunisia, Japan, and Singapore. And they're all asymptomatic patients, meaning that they didn't have any significant neck pain or back pain, and their overall functional scores were also quite high. And so we looked at these patients from the age of 18 to 79, and what we did was we applied the age-adjusted essentially targets to these patients to see if they would have similar alignment to what they have as they're asymptomatic, or if they would be under or overcorrected. And what we found in our study was that if we applied the age-adjusted alignment targets to our asymptomatic cohort, we would leave a vast majority of these patients with a much more forward malalignment than they have currently. And so this was obviously quite interesting because we all deal with older patients, we all deal with deformity patients in the SRS, and the cohort that we use, the means cohort, does include a good number of older patients. And so it really challenges the idea that older patients should not have the same good alignment as the younger patients. And that's what we kind of saw in our study. What we saw was that even in the older age group, if we followed the age-adjusted guidelines, we would unfortunately undercorrect these patients by even up to 15 to 16 degrees as far as the lumbar lordosis is concerned. That's quite significant. And so that was really the basis of our study. We wanted to show how well applicable these goals are to older patients who are less symptomatic. And as we all know, we are operating on these older patients to decrease their symptoms. We're not operating on them to say that, hey, you're going to have a certain level of high disability and we're going to fix you in that position. The goal of surgery is really to decrease that disability. And I think that's what our study is really showing, that even for these older patients to be less symptomatic, they do need good alignment.
It sounds like some pretty important work. The literature that's been established to describe target alignments for different ages has matured, right? So it's not just a simple calculation. It's now been correlated in multiple subsequent studies with risk of things like PJK and other complications. And so your study sounds like you showed that maybe the population that those goals were derived from might have already been symptomatic and perhaps had more malalignment than asymptomatic adults. But does that mean that we need to alter surgical goals to turn back the clock and make them like people who never had any disease? Do you think that might put them at risk for some of the junctional complications that we're trying to avoid?
Yeah, great point. So I think number one, you're right. The goals are derived from this symptomatic population, and it's derived in kind of a reverse engineering type of way to say that older patients will have a certain level of disability, and so keeping that in mind, this is the alignment they might have. Now, your question about, well, do we really need to make them completely asymptomatic? And that's a good question. The studies have really looked at, for age-adjusted, have primarily looked at PJK as the main outcome. And yes, if you are undercorrecting patients, you may have less PJK. But as we know, other studies that are coming out and have come out also show that patients who are undercorrected have other types of mechanical complications, mainly pseudoarthrosis and rod fractures. And we have actually tested that in our symptomatic cohort of deformity patients that we at our local center we have operated on. And we have absolutely seen that if you undercorrect patients, such as following goals like the age-adjusted, you have lesser rate of PJK, but you have a significant increase in the rate of then mechanical complications, including rod fractures and pseudoarthrosis. So you're kind of trading off one mechanical issue for the other. I think in the adult deformity world, we are obviously PJK continues to be one of the biggest problems that we face because that typically tends to happen early on. But as we continue to follow these patients, then a couple of years, and we don't have to follow them for too much longer. You follow them for another, year or 2 years, and then you start to see the other side of things, which is the pseudoarthrosis and the rod fractures. And we do see that patients who are undercorrected have a higher proportion of those complications. I mean, again, this study doesn't really say that we need to correct everyone to the absolute asymptomatic alignment. We have also looked at what we call a sweet spot in terms of kind of trying to find a balance between the PJK and undercorrection. And there is such a thing where you can try to find that fine balance. And I think that's really what we're trying to look at. But this was really to show that if we grossly undercorrect these patients and follow some of the older rules now of age adjusted, at least from an alignment perspective, we're really undercorrecting them. And there's a lot of studies, including from our centers, which show that those patients can then have, number one, their ODI and SRS scores are then impacted as well. But then also later on, they have rod fracture and pseudoarthrosis type of complications. So we may avoid the early complications, but then you're going to have the later complications.
Yeah. And one of the things I saw that I thought was interesting is it sounds like you didn't find that the goals were entirely wrong in the same way for the entire population. You found some systematic differences, like patients maybe with a higher PI or patients that were older were not adequately represented by the age-represented goals. Is that accurate?
Yeah, absolutely. So what happens to the age-adjusted concept, again, kind of deviates more from the norm as you get older. Older patients are assumed to have higher levels of disability. And so in our asymptomatic population, obviously, as the older patients from the age-adjusted concept then deviate a lot from our asymptomatic population. And so that's why what we saw was that younger patients, the difference from between age-adjusted and the asymptomatic population was less. But the older patients, that's where the difference was a lot more magnified. And the same thing happened with pelvic incidence, as with the extremes of the pelvic incidences where we saw that the deviations were much higher. So if you kind of take someone in a younger age, average PI, the difference was probably the smallest for that age group, for that group of patients. Your young patients with average PI, but your older patients with a high PI, that's where you deviated the most from the age adjusted.
So it sounds like you did find some variation with age. So maybe we shouldn't throw out the concept of age-adjusted goals entirely. But what do you think is the next step? Do we need to come up with some new rules or some new goals?
So the reason we found the difference with age is because by design, age adjusted creates a bigger difference as you get older. So that's really it's by design, that philosophy that's introducing that, not so much the asymptomatic cohort that's introducing it, right? So I think there's that inherent bias in a way. So, but to your point, again, I think there's just so much more that we need to learn about these issues. Again, older patients who are symptomatic and want to be less symptomatic, maybe there might be somewhat of a less correction factor there. But what we are finding is that it's probably not as exaggerated as what the age adjusted is saying.
Great. Well, congratulations on your word, and thanks for sharing your work with us today.
Hey, thank you very much, John, and thank you for letting me talk on this. And again, thanks to all the co-authors and the whole group who participated in this.
Great. Okay, so next we can move on to Dr. Jain, and he can tell us about his paper.
Sure, thanks, John. So our paper focused on skeletal maturity in children. So skeletal maturity assessment is important for management of scoliosis. It impacts both the timing of management as well as of surgery. So thinking about whether someone should qualify for a brace, how long we should keep them for braced, and whether we should offer them surgery. Frequently, the Sanders scoring system is used to make this evaluation, and it's the gold standard. But unfortunately, it requires a separate hand radiograph. So the idea behind this study was fairly simple. It was, can we use a routine scoliosis radiograph, which already has a bunch of clues, and can we put these clues together to make a comprehensive picture of the patient's skeletal maturity. So by these clues, I mean, we already frequently use Visser, we frequently use triradiate cartilage. Proximal femoral ossification was something that was previously introduced by the Hong Kong group and is certainly a very good system. And then the proximal humerus ossification was introduced by the Texas group and another well-validated system. So the question is, if we can capture all four of these things in one picture, can we put them together into one comprehensive skeletal maturity index to get a sense of how much growth is remaining and whether that correlates with the Sanders score? So that was the crux of the study. So a fairly simple innovation. And what we found is that when you put it all together, we had 200 and something paired scoliosis x-rays with hand x-rays, and then majority being girls, some boys. And we found that the Sanders and the CSMI, which is the Comprehensive Skeletal Maturity Index, which was just a simple summation of the four indices together, actually had very high correlation, almost 96% agreement, which basically meant that you can, for most cases, not need a hand x-ray to be able to tell where the child is along their growth spectrum. Obviously, the scaling is different, right? Because the scaling is just a raw summation of each of those things. And there's more discussion to be had whether that's the most accurate way to do this or whether there needs to be a weighted system or something more sophisticated. But the broad concept is this. We have a lot of clues that relate to growth that we can take from a simple radiograph, and we should be able to take those clues together and get a sense of what the child's skeletal maturity is and hopefully save a ton of kids radiation. Now, there were some mismatches, and interestingly enough, one patient had a CSMI that was underestimated from the Sanders. So in other words, it wrongly predicted that the patient was pre-peak height velocity, and then 7 patients overestimated Sanders. So which again, talks about how there may be different maturation centers that may not have perfect reliability with each other. And part of it is that I think growth affects different parts of the body differently. And sometimes there may be mismatches that may physiologically exist. So it's not always a one-to-one correlation. So in summary, our study was a fairly simple concept, and the concept was use all the clues on a standard radiograph. And if you ask your radiographer to capture all 4 of the growth clues, including the proximal humerus, including the proximal femur, the triradiate, and Visser, you can make a better evaluation of the patient.
Awesome. That's some great work. I have a lot of interest in skeletal maturity, as you know, so I was excited to see the results of this come together. And it's interesting that you mentioned the concept of scaling, because that was something that I had a big question about, because the difference between a Sanders 3 and a 4 might be different than the difference between a Risser 3 and a 4, but in your system, a Risser 3 and a 4 and a proximal femoral classification 3 and a 4 have the same value. And so I wonder if you had a way to adjust for that, do you think that could make your results more accurate?
Yeah, definitely. I think this is just a first stride toward this concept, where definitely more work needs to be done, and we're thinking about how to use maybe principal component analysis or a more sophisticated statistical method to figure out relative weighting of how these things should be summed instead of a simple addition. Right now, we just arbitrarily added them up on a scale, and which doesn't make the scale linear or intervaled. But I think your point is well taken, and there probably needs to be a more sophisticated way to kind of combine these things together. But I think what was impressive to me was that even in this fairly crude summation, it actually did a pretty good job. Maybe it can't predict between a Sanders 3A and a 3B, but it certainly does a good job predicting between, who's Sanders 2, 3, 4. And that's probably good enough for majority of our patients, with the exception of those we're thinking about growth modulation techniques.
Yeah, and I think one of the things that was really interesting was the concept of mismatches that you mentioned, because each of these scales are ordinal scales that are sequential within themselves, but they can occur at different overlapping times in the same patient. And so you sort of assumed, it sounds like, that Sanders was your gold standard for assessing peak height velocity, but maybe it wasn't. Maybe your scale was correct and Sanders was wrong in the mismatch cases. I mean, how do you
Yeah, I
think
think that's a
about
really
verifying
interesting.
that?
Yeah, I think I totally agree with you. I think that's a super interesting question. Um, our next step with this is to externally validate this with the data source that's beyond the Hopkins source. And I think ideally we would love to have a source that has accurate measurement of height temporally over different time periods, and then kind of see what happens in terms of those mismatches. I think that would be super interesting. The other thing is there's a nice paper out of the Turkish group from Dr. Çağlar Yılgır from their group looking at how those temporal mismatches do happen, where somebody may be, for instance, a Sanders 3, but their proximal humerus score may be a 5 or, or something else. And I think it's interesting because physiologically those mismatches do exist. But the question is, how do you take all the different growth scales and put them together to kind of get a comprehensive view of the child as opposed to just arbitrarily assigning one gold standard?
Right. I think we tend to hang our hat on the one that's maybe has the best inter and intra-rater reliability, but that just means that we agree on it. Doesn't necessarily mean that it's a true predictor of what we actually care about, which is growth of the spine.
Yeah, ultimately we'll probably have to move towards some kind of a biological scale that's a blood test type of situation, but I'm not sure if we're there yet.
Yeah. Cool. Well, thank you for sharing your work with us. And then we'll have next, we have two authors who are going to present their work about the best e-poster award. Dr. Zhu or Dr. Liu?
Okay, thank you. Our study mainly investigates the process of a compensatory curve and on the impact of the postoperative curve progression in congenital scoliosis patients following the thoracolumbar hemivertebra resection and short fusion. And we all know that hemivertebrae located in the thoracolumbar region are reported to progress rapidly and more likely to cause deterioration of scoliosis. And if left untreated, the initially unaffected neighboring vertebrae are susceptible to subsequently developing a compensatory curve. This compensatory curve may alter the biomechanical environment of the spine and cause potential low back pain. Besides that, the hemivertebral resection and short fusion has been the mainstream surgical approach. It remains unclear whether this surgical strategy is still applicable for CS patients with a preoperative compensatory curve. So in our study, the purpose of our study is to investigate the impact of the compensatory curve on the postoperative curve progression. So generally speaking, our study have two steps. The first step is to compare the incidence of a postoperative curve progression in patients with and without compensatory curve. And we found that a total of 127 patients were included, and we found that the incidence of postoperative curve progression was significantly higher in the compensatory curve group than that of the non-compensatory curve group. And in the second step, we try to find out the mechanism to explain the higher risk factors of the postoperative curve progression in the compensatory curve group. And we find that patients who experienced the postoperative curve progression showed fewer fusion segments and greater preoperative UIV tilt. And through the multiple logistical regression, we found that the shorter fusion segments and greater postoperative UIV tilt were two independent risk factors for the postoperative curve progression. So in conclusion, our study mainly talk about that we mainly find that the presence of a compensatory curve was associated with a higher incidence of postoperative curve progression in patients with CS who underwent the thoracolumbar hemivertebral resection and short fusion. And the second point is we find that the shorter fusion segments and greater postoperative UIV tilt were found to be the risk factors for this phenomenon.
Great. Thanks for that summary. I think that's some really important work. I think a lot of us who treat congenital scoliosis worry a lot about progression within the congenital segment, but I personally worry just as much about what it's doing to the normal adjacent spine above and below. And so you just showed us that we should definitely pay attention to that, at least in terms of risk factor for progression after surgery. So we now have one expert who's presenting on skeletal age and another on congenital scoliosis progression. Tell us about the skeletal age of the patients in your study. Did it differ between the groups that you compared?
Uh, sure. All the patients in this study, the inclusion criteria of this study is that we include the patients who are less than 10 years old. So we're trying to do a uniform surgical approach, and we do the thoracolumbar hemivertebra resection and short fusion. As shorter fusion represents that the fusion segments less than the 4 segments. So basically, our surgery is try to is mainly to alter the progression of the main curve, and we find that for patients who already behave as a compensatory curve, it mean represents a spontaneous response to offset the primary scoliosis. And furthermore, the emergence of the compensatory curve is we maintain that it is often accompanied by mechanical and morphological changes in the vertebrae and the parovertebrae soft tissues. So if these changes have already become structural, the preoperative secondary curves may recur postoperatively in order to reach a new trunk balance after the initial surgery. So basically speaking, our studies highlighted that the presence of a compensatory curve may serve as an indication that we should perform the surgery and enhance the importance of early surgical treatment.
So how did you pick 20 degrees as your threshold to call it a curve or not? Why not 15 or 30?
Generally speaking, the 20 degrees is in previous study, most studies they define the 20 degrees as the threshold of the compensatory curve. And in addition to this, we put another point is that the cobble angle alone may not accurately identify the presence of a compensatory curve because the hemivertebrae the hemivertebrae may be oblique in the upper or the lower point of this hemivertebrae. So we put another point is that the UEV and LEV tilts toward different directions as the supplementary of the definition of the compensatory curve.
And how about bracing? So in my practice, I will often manage a compensatory curve with a brace, sometimes pre-operatively in a patient I'm not sure if they're going to need surgery, or even post-operatively in a patient who still has a compensatory curve after I've done surgery. Did any of your patients get braces?
Yes, that's a great point. And with regard to the management of the curve progression after surgery, we also recommend brace treatment, and we maintain that. So the characteristics and development of the postoperative compensatory curve, they closely resemble that the adding on phenomenon observed in patients with AIS. So as a result, we find that the bracing is equally effective for patients with CS, since the curve is relatively slight and flexible and at their age. So in our study, we also found that the progression of the deformities was successfully controlled by the brace treatment.
Great. Well, thanks for sharing that work. How about any comments from any of the other authors? Do you guys manage congenital scoliosis in your clinics? Do you use the compensatory curve as a decision maker for when to pull the trigger on an operation or treat a patient differently?
Uh, yes. So I would like to, I would like to supplement for the first question you've asked. I think certainly the skeletal maturity has a very important influence on the outcomes. And actually, after our paper, actually, this paper has been published in European Spine Journal and this presentation. And after that, we have received a comment from a different research group, and he also raised similar questions about the skeletal maturity. So actually, we wrote a reply, and it's also been published. There's a reply. So we did a further subgroup analysis of these cohorts, and we further divided these patients of age younger than 5 and age from 5 to 10. So we have this subgroup analysis. And very interestingly, we found that in the younger patient group, the incidence of postoperative curve progression was significantly higher than the another other group. So this also highlighted that the patient age is also a very crucial factor for the postoperative outcomes. But we so far we've been observing these patients with co-progression, like Dr. Xu have just introduced. Some of the patients are well the curve are controlled with bracing treatment, so we did not observe any kind of implant failure or mechanical complications. So I think it's definitely accepted for the risk factors we have identified, like the UIV tilt, OIV tilt, and skeletal maturity is certainly an important point to study. So in a future study, we may integrate skeletal maturity and also the timing of intervention, and to build a more comprehensive model to more precisely predict the outcomes and the risk of co-progression after short segment fusion in these kind of cases. Thank you.
Thank you for that contribution. I think it's so interesting to hear to go to a meeting like IMAST or SRS and hear management stories about congenital scoliosis, because in the people that I've talked to and the communities that I've had a chance to work in, it seems like everybody has a slightly different threshold for when they'll decide to treat and when they'll decide to observe. So maybe if we could just do a rundown about what are everybody's indications for when to take out a hemivertebra in a patient under 10 years old.
Yeah, exactly. Exactly. I think it's yeah. I'll say even in China, I think different surgeons in different centers, they have different criteria of selecting the optimal time for the best indications for surgical treatment, or the best indications for the bracing treatment before surgery and after surgery. So definitely requires more research.
What about you, Amit? When do you take out a hemi in a patient under 10?
Yeah, I think more than a 40-degree curve with more than 10-degree progression, so documented progression, would lead me to be pretty aggressive and take it out. Obviously, I think not hemis are created equal, right? Some congenital patients have a focal hemivertebra, which is really the driver of the deformity. Others have multiple congenital deformities where it's pretty well balanced, or they may have areas of autofusion and so on. So I think you have to kind of think about it case by case basis. But I think for the patient who has a focal hemi that's really driving the major curve, and there is any progression, I'm pretty aggressive.
Yeah, just I would say similar, in terms of your absolute goals and progression. And progression obviously is a very important one if you're starting to see more than like 5 degrees or max like 10 degrees of progression in someone who has congenital scoliosis and has a lot of growth left. Even if the absolute curve is not that big, I think you sometimes you do pull the trigger a bit, or even on smaller curves, for especially for early onset, with kids, a lot of growth left. And some of it obviously will depend on the resources of the place where the kid is being treated. So I think that's why, as you're talking to other people in the at IMAST or SRS, the nice thing about SRS and IMAST is they're international communities, and you get people from all over the world with different resources, and that's probably why we have a bit of a different threshold level in terms of like how soon you operate on them. when I was in Tanzania a couple of months ago, and obviously there the threshold is going to be very different. And even though bracing is not truly used for congenital scoliosis, that is a situation where things are a bit more in terms of conservative, because there's a lot more a lot of other kids who need treatment before they get to more of this prevention strategy type of situation. So I mean, I think that's why we see the variation a little bit, especially in the younger kids.
Yeah, it's a good observation, and it's a good thing about these meetings that we get to hear different perspectives, because we can see how things happen under different management strategies. It makes us all a little bit better. Wonderful. Well, thank you all for joining us, and congratulations to all of you for some great papers and for the awards that you've received. And thanks for sharing it with us on the podcast. Any closing notes from anyone?
Well, thank you very much for having us.
Yeah, thank you. And hopefully our IMAST 2026 in Toronto will be another great showing with some great papers. So I hope everybody can come join us.
I'll be there. Toronto is great.
Be there or be square.
All right. Hi. Thank you. This is Jeff Mullin speaking now. Going on to the next part of our IMAST Focus SRS podcast. We have joining us Dr. Yu Du, who was the Whitecloud winner for the best basic or translational science research paper at this year's meeting. His paper was on the novel growth guidance system in research and development. Hey, Dr. Du, please tell us a little bit about your project.
Okay, thank you, Dr. Mullin, and thank you for the introduction of my research topic. And actually, my research topic of this year's IMAST is a novel growth guidance system in research and development. And actually, the idea of our novel growth guidance system was basic on the traditional spinal growth guidance system with the limited apical fusion, and because this kind of instruments have already used in China also, and during the use of this kind of system, we found there's kind of disadvantage of the traditional system. One of these the weaker ability to promote the growth, and we think the reason of that is this system are lack of the distraction force, and also the metal to metal sliding interface may constrain the sliding. And also we found that there's metal debris by using the traditional growth guidance system. So we hope to overcome all of those disadvantage of the traditional system. So we establish this novel growth guidance system. Actually, we made two modifications to the traditional system. And first one is we put the ultra high molecular weight polyethylene gasket on the rods, and that gasket can perfectly fit it into the tulip of the screws, sliding screws. And also we polished the sliding part of the rod, and both of these modification can reduce the sliding force between the sliding screws and the rods, and also can reduce the metal debris. And when we established this system, and we made some in vivo tests, and also we made some in virtual tests. And first, we first made some in virtual tests, and also we used a fatigue test to test our system is durable enough to fit in the patient. And also we made a sliding displacement test in order to make sure our system got a better sliding ability compared to the traditional one. And then we put our system into the 6 months old immature miniature pigs, and in order to check the system's ability. So during the in vivo experiment, we found our system can sliding perfectly in vivo, and also the system will not produce the metal debris, and also the biocompatibility of our system is pretty well. So in the future, maybe we will conduct more clinical trial of our novel growth guidance system in the patient, and then we hope this system will got a better performance in the patient in the future.
That's very interesting. So near that next step, you're talking about possibly getting into clinical trials. What do you think are your next hurdles to clear before that possibility happens?
Actually, in the future, maybe we will put our novel growth guidance system into the track of the Chinese FDA, and then we hope our basic research and all of those experiments can pass the supervise of the China's FDA, and then we later maybe we will got the certificate of the Chinese FDA, and then we will put our system on the patient. Yeah.
Well, it could be very exciting. So good luck to you with that. Obviously, it's probably an arduous process to get all those approvals, but I'm confident you can get that. So congratulations again on your Whitecloud Award, and we look forward to seeing the next iteration of your research.
Thank you, Dr. Mullin.
You're welcome.